Hello, and welcome back to Chapter 15, Part 2 of Psychological Therapies. Today, we're going to spend our time talking about cognitive behavioral therapy, and we're going to talk a little bit about the contributions of Aaron Beck and Albert Ellis and his rational emotive therapy. I'll mention a few things about group therapy and self-help groups. We'll talk a little bit more about the effectiveness of psychotherapy, basically what works. And lastly, we'll talk about psychopharmacology today. I'm not really going to get into the psychosurgeries and ECT and some of the other types of interventions and emerging therapies. So obviously you need to read about that stuff, but none of that material is actually going to be on the Canvas exam this week. There's plenty to talk about between cognitive behavioral therapy and psychopharmacology. For cognitive therapy, Aaron Beck is absolutely a name you need to be familiar with. As a side note, during a conference several years ago, my wife actually got to dance with Aaron Beck. It's a bit surreal to meet somebody in real life who you've read about in the textbooks. Anyway, as mentioned in the book, cognitive therapy focuses on distortions of thinking. So be familiar with the 5 common distortions mentioned in the book. That's the arbitrary inference, selective thinking, overgeneralization, magnification and minimization, and personalization. Now, the thing I want you to keep in mind is that these are common thinking distortions that all of us engage in at one time or another. The value here is recognizing the thinking traps that you might fall into so that you can make adjustments. Imagine how many arguments or hurt feelings could be avoided or minimized if we recognized when we were responding to a distortion in our own thinking or beliefs. I think the old saying, "the truth will set you free," certainly applies here. Holding on to more accurate truths and beliefs will almost always make us feel better than trying to justify lies. Cognitive behavioral therapy is based on the idea that changing how you think, that's the cognitive part, can change how you feel and change what you do. The term cognitive behavioral therapy is broad enough to describe multiple techniques to address multiple problems. So Albert Ellis, who's mentioned in the book, and his rational emotive behavior therapy is a great example of simple but really effective application of the CBT model. If you ever get a chance to see training videos on Albert Ellis, he's a really interesting character, and he works very differently from somebody like Carl Rogers, who we've been talking about. As the book mentions, therapists from this perspective tend to be much more directive when they challenge the rationality or the accuracy of beliefs. If you remember from Chapter 11, we reviewed the cognitive model. That's the A plus B equals C, where A is the activating event, B is the belief about that event, and C is the emotional consequence. Basically how we feel as the result of the combination of what we think about things that happen to us. This is Ellis's model and the basis of a lot of therapies that are still being used today. At the VA where I work, for example, we use a variation of this called CPT, Cognitive Processing Therapy, to help our veterans with PTSD, post-traumatic stress disorder. This type of therapy can bring up a lot of painful emotions, but I've personally seen a lot of really good benefit come from this. I recall one of my veterans telling me one day how difficult it was to work through this process because it just stirred up so many memories and emotions for him. And I asked him plainly, I said, well, was it a mistake for us to do this CPT? Should we stop? Without hesitation, he said, no, it's been really helpful for me. I'm just telling you that it's hard, it's difficult. He completed all 12 weeks of the therapy, and he worked really hard and really made a lot of good progress. I still talk to him, and he tells me that he still uses some of these techniques when different kinds of other issues come up for him as well. Like many different kinds of therapy, when it's done well, it can really be life-changing. I think there's a lot of people who consider group therapy to be second rate or something you do if you can't get into real therapy, meaning individual therapy. And that's too bad, in my opinion, because I think there's some real advantages to group therapy. For one, if you have the opportunity to get multiple perspectives on what's going on for you versus just one, that's always going to be a benefit. My experience has been that even with a trained professional, they're still going to miss things that other people in the room are going to be able to pick up. Also, I think it is extremely helpful when you're in a group where sometimes you're getting support and help, and sometimes you're offering support. Let's be honest. I think it's very easy for a client in therapy to assume that the person you're talking to, the expert, knows everything, and therefore you don't know anything, which, by the way, is probably a form of a cognitive distortion, right, that Aaron Beck would love. And as a result, it becomes really easy to stop trusting your own judgment. And so you stop wrestling with difficult problems on your own because you don't believe that you can help yourself. A group can really help you appreciate that you have insights and thoughts that can help other people and therefore can help yourself. For self-esteem and confidence, I think this is a big deal. This is one of the reasons I'm a big fan of self-help groups and peer support groups of all kinds. I think I've mentioned in the past that there's some research that suggests that just because a person is well educated, has a lot of experience and training, does not always translate into better treatment. I think self-help groups are a great example of this. Section 15.8 in the book addresses effectiveness of psychotherapy. Now, I think it's a fair conclusion to draw from the research that psychotherapy in general tends to help people and is effective. What's interesting to me is what seems to make therapy effective. As we just mentioned, the type of psychotherapy that's used, whether the therapist is licensed or not, the level of education, the years of experience, are all relatively insignificant compared to the rapport or the therapist's ability to connect well with the client. The book calls this therapeutic alliance, right? That therapeutic alliance, that rapport, that connection is the single best predictor of therapeutic outcomes. That's the thing that matters the most. The research that I've looked at seems to indicate that a therapist who is skilled at building rapport, showing warmth, empathy, understanding, right? All those kinds of things to build that connection. The person who does that well is probably able to do that with a wide range of people presenting with a wide range of problems. Now, it helps if the therapist knows the therapeutic techniques and can execute them well, but it also matters that the client agrees with the therapeutic approach and it makes sense to them. The bottom line is this: by far, the therapist's ability to relate well to the client is the thing that matters most. Okay, psychopharmacology. Now, this is a huge topic, and there is no way to do it justice in just one part of a chapter in an introduction to psychology class. This topic alone would easily take up a whole semester to begin to get a handle on it. What I want you to be aware is that there are different categories of medications that work very differently. So the antipsychotic medications like Seroquel or Risperdal are the best tools we have at this point for treating the positive symptoms of schizophrenia, like hallucinations and delusions. But there are some significant side effects, which leads a lot of people to not want to take the medication. It can really flatten their affect, and weight gain, for example, are just two very common symptoms. So one of the difficulties is, although traditional talk therapy can help, we really don't have a good substitute for medications for these significant psychotic symptoms. Other treatments can supplement good medications, but really can't take the place of them. With the anti-anxiety medications, the benzodiazepines. Examples of this are Xanax, Ativan, Klonopin, Valium. Clients like them because they work very quickly and they work effectively in the short run. Providers, however, do not like to prescribe these medications because they're quite addicting. And here in the last maybe 10 years or so, there's just been a lot more pressure on providers to be really cautious about the medications that they provide because of the safety risks of controlled substances. I know a lot of providers these days who will not even prescribe these medications at all. Now, from a psychotherapy perspective, my concern is that people might be less likely to want to practice and learn some of the behavioral and cognitive management tools that the research says is really, really effective because they'll primarily rely on the medications to help them feel better. And by the way, from the research, anxiety medications really are not more effective than good old-fashioned psychotherapy when it comes to managing anxiety. Mood stabilizers. Lithium or Depakote are typically two mood stabilizing medications that are used for bipolar disorders. They don't do a lot for the depression part of the bipolar disorder, but what they do is they help put a lid or an upper limit to keep the person out of going into manic episodes. So the mood stabilizer is really for the manic episodes, much less for the depression. So we've talked about this before, but getting a good diagnosis of a bipolar disorder versus depression is really crucial, particularly when it comes to the medications. If you give someone with a bipolar disorder one of the typical antidepressants, we'll talk about that in a second, the SSRIs, it can actually bring on a manic episode. Nobody wants that. So if an antidepressant of some sort is going to be used, it's almost always going to be used once the mood stabilizing medication is introduced first, get a good upper limit, good handle on the manic episodes, and then they'll come in with a secondary medication to help with the depression. All right, for depression these days, it's all about SSRIs, selective serotonin reuptake inhibitors. They're the first line go-to medications for depression these days. And there's good reason for that. Generally speaking, these medications are pretty safe. They're not addicting like the pain medications or sleep medications or the benzodiazepines. And they work pretty well. They can be very effective. So they are the most prescribed medication out there these days, not just for depression, but also for anxiety. By the way, your regular medical provider prescribes about 80% of all psychotropic medications, not psychiatrists, and they mostly are going to prescribe the SSRIs. One thing to keep in mind with the SSRIs, if there are side effects, they usually tend to be present the first 2 weeks or so, and then they drop off very rapidly. However, the beneficial effects of the medication won't kick in for about 3 to 5 weeks. So it's helpful to understand that the person needs to stay on the medication long enough to get through the side effects and then to feel that benefit from the medication in about a month or so. Also, if the SSRI is helpful, it's recommended that the person stay on the medication for at least 6 to 9 months from the time that they notice a good response to the medication. The idea is similar to taking an antibiotic. You might feel better after 2 days, but you're told to take the medicine for maybe 7 to 10 days because if you stop too soon, the infection can come right back. It's the same idea with the SSRIs. If the depression responds really well to the medication, you want to stay on the medication long enough so that the depression stays away. When you do that, the odds of the depression coming back go down dramatically. It also gives you a chance to implement some other good coping tools so that when you're off the medication, the depression stays away. So this would be a good time to practice some of those cognitive behavioral skills that are mentioned here. As we've talked about in past chapters, this is a really good time to get some of those habits on track. Exercise, socializing, purposeful and pleasurable activities. All those things together can help the depression stay away even once the medication is stopped. Last thing about the SSRIs. Even though they're not addictive like sleep medications and pain medications and the benzodiazepines, it can still be uncomfortable if you stop the medications too quickly. So you want to taper down off of the medication slowly. Table 15.3 gives a pretty decent summary of the different types of medications out there. So that's our last video lecture of the semester. Be sure to do all the things that you've been doing all semester, the Revel quizzes, the Canvas chapter exam. You have a discussion board this week. And after you finish that, it's just going to be a matter of just preparing for the final exam. So you're so close. You're so close. Hang in there. Stay focused. Finish strong. Go take care of your business.